Good day. Hello, Kate. How are you?
Hi, Walt. I'm doing well, especially after our Super Bowl win last night.
Yeah. Good for you. Good for you. So can you introduce yourself?
Yes, so my name is Kate Hoener, and I'm a speech language pathologist located in St. Louis, Missouri. I work at Missouri Baptist Medical Center, primarily in outpatient therapy 4 days a week, but I do often float to acute care there. And then I work at Mercy Hospital, and I have my own mobile fees business. And since I'm a glutton for punishment, I also recently accepted a clinical instructor position, an adjunct position teaching graduate level dysphagia at Maryville University. So
Great. Well, you're busy.
yeah,
Yeah,
gotta have a, you know, place to apply all the things over the
exactly.
years.
Exactly. So you've been doing this work for a little while now in terms of incorporating some of the manual therapy into your into your practice. Can you chat a little bit about that?
Yeah, so I first took your course in, I think it was San Francisco in 2021. We were in a tiny
Oh,
yoga
yeah.
studio.
Yep.
Yeah. And so I, at that time, was working primarily in home health, outpatient, like Part B, doing home care. I was also in assisted livings. I was still doing acute. And so I was seeing every patient population under the sun, as far as stroke, head and neck cancer, breast cancer, dementia, Parkinson's, you name it. I saw everything. And so I was really intrigued. I know Brooke Beelman and I kind of right off the bat started experimenting because we love to feed each other. And so we were experimenting with what manual therapy looked like externally, internally. So because we like to do everything under instrumental to try to see what it's impacting internally. And so when we kind of, were eyes were open to the power of this technique immediately. And she had turned me on to your course years ago. And so I started implementing this with head and neck cancer patients with Parkinson's disease that had a lot of rigidity, spasticity with stroke patients. And so it just kind of was like a waterfall of options that I never had before in our, clinical toolbox. And so I slowly started implementing, I don't know, the oral strategies first primarily, and then kind of moved into the stretching of the, different parts throughout the body. And it was just mind-blowing to see the impact, not only anatomically speaking, but that we can have with the rapport building. So that's kind of how it started.
Yeah. You know, you'd said you took the class in San Francisco, and I can vividly remember that class because it was such a small room. And I remember, I think it was on the second technique of the first day. We started the lab, and I said, okay, here's what we're doing. And I was a little ambiguous, and I'm trying to work away from ambiguous and being more concrete. But I can vividly remember somebody in the back corner of that second room just screaming, "What are we supposed to be doing?" And that was left such an imprint on me because I know that I frustrate some clinicians because most people, when you take manual therapy, they talk about what your target is, what it is you're supposed to accomplish with your evaluation and your hands, almost as if what muscle or what fascia or what specific structure we're supposed to be impacting. Whereas my little cloudy approach is we're supposed to be impacting something that's relatable by the patient. Now, since 2021, when you took that class, when there was that outburst in class, I've definitely done a better job with translating that to new learners. But did you find that frustrating in the beginning? I'm kind of curious.
I try to go in with an open mind because I know perspective is huge, and I know our field is always changing. And so I never, fully I thought it was an interesting perspective, but I also was a little biased by your work ahead because I knew some of the benefits already from other clinicians.
Yeah.
So I think that's why I still decided to pursue it for the betterment of patient care.
Yeah.
So.
Yeah. And I still get beat over the head with, I'm not anatomical enough. I'm not specific enough with saying what structure we're impacting. But I kind of hold myself at a distance from that on purpose, not to irritate people, but just to sort of hold my ground and say, no matter how much we know about anatomy or physiology or function or form, there's still that ambiguity of working with another human being and knowing for certain, can we really know for certain what's wrong? And can we really know for certain exactly what our mechanism of action is? And I guess it's just the cross I'll have to bear with trying to translate that to people and to new learners.
Well, I think too, adding on that fact, if we can still demonstrate positive clinical gains with standardized testing, patient-reported outcome scales, quality of life scales, we can measure it, through specific measures with, fees, utilizing it as, biofeedback, showing, I can describe this as, in the hypopharynx, this is the oropharynx, this is, a roundabout exploration of what this area looks like, and we're positively impacting the amount of residual or the amount of pain or strain. I think those can still be very objective measures in a still realm of ambiguity, if that makes sense.
Yeah, absolutely. So you've been successful in sort of transitioning this relatively ambiguous model, as I call it, into your clinical model using objective measurements and on. I think that's important for people to know that it's not just funny, artful or fuzzy, artful work. It still has, a pretty firm grounding in the evidence and then easily inserted into your interventions. And I don't mean to put words in your mouth, but is that the case for you?
Absolutely, yes. And I always explain to them that this is an adjunct tool in our toolbox of things, but it also can serve not only as an adjunct, but full clinical intervention depending on what patient population we're working with. And so I always educate the patient, as we should do with clinical decision making, evidence-based care, patient-informed consent. This is what we're doing. Is there, a plethora of research supporting the exact anatomical location, the impact on the swallow physiology or the speech mechanism? It's evolving. We are working on it. But, I think being transparent in the fact that I've seen this happen with other patient populations, we can try this, and then giving them, full decision-making capacity to implement that, whether or not it's ambiguous to us as clinicians, but to them, it might make complete sense.
Right, right. So if you had a piece of advice for a new speech pathologist, either just taking the work and figuring out how to apply it, or somebody who's just considering it, I'm kind of throwing this question at you without any preparation, but do you have any tips or advice on incorporating it or the usefulness of it?
So tips of advice for clinicians when they're starting manual intervention, typically, number one, I always let the patient lead. So kind of expanding on that, I educate them to the potential that there could be large gains, that they could, feel improvement after one session. I give them education that it might not impact them at all. I give them education to, the sliding scale of changes that could be possible. And I let them decide after I educate them a little more to what it looks like if they want to incorporate that into their treatment plan. As long as there's no, contraindications or things like that. Second, looking into letting the patient lead, I always kind of, if I'm trying to discern where to start with them anatomically, I'll ask them, can you guide me where you're feeling the strain or the discomfort, whether it's orally or, more downstairs in the thoracic region. And then I actually have them do hand over hand with me, and I have them lead every single time where they feel that, so we can start the process together, because I feel like, in my past experience, when I've automatically gone to attempting to find the place, as you always say, your dignity's in check. It's always checked at the door. So I always have to adjust. So now I just have them lead and go from there. And then again, I'm always checking in with them. How does this feel? What's your ceiling of pressure? On a 0 to 10 scale, I always try to make sure I'm staying away from, what could elevate their level of discomfort. I'm checking in with them. I'm just going to hold this. I'm going to prolong this stretch. You let me know if this starts to become, discomforting. I will often put a full length mirror in front of us, so the patient can see too, like what I'm doing to them externally. I found with my patients that have more anxiety about manual that this is super beneficial and helpful. And it also helps them understand a little bit more about where my hand is placed, to then reinforce a home program for manual stretching at home for them, which I've found a lot of patients love, because they feel like they have more control over their diagnosis or what's going on with home programs. And then I always ask them and give them the opportunity to decide where they want to do therapy. Like, I do have the luxury of, I have an office, but then I also have a huge gym where there's about 50 PT and OTs, and we have extensive mat tables. And so if it's a patient that I'm concerned about, or they're concerned about, more one-on-one personal touch, they will often say, yeah, let's go out to, the treatment room, out with the other clinicians, which has also been kind of fun to see PT and OT, looking at me like, you're a speech language pathologist. What are you doing over here? And so, but I've gotten a lot of, like good questions. And I actually had a patient, muscle tension dysphonia patient, and I've seen her 3 sessions now, and she has almost prior level of vocal quality. And she's studying to be a doctor. And so she was discussing about how she had no idea that manual therapy and, this type of stretching and intervention was in a speech pathologist wheelhouse. So that was pretty cool to also have a conversational piece as we're kind of doing these stretches. I also give the patient rights to, do you want to do a specific amount of certain stretching? Like, I'll give them 3 or 4 different stretches that we've introduced over the last few sessions. Or I'll say, do you want to do prolonged stretches, where I'll hold for like 15 or 20 minutes in the same location? Again, just giving them more power to their treatment, and seeing, what do they prefer? Because I might say, oh, well, I noticed the intraoral work was more beneficial, whereas they might have said, well, it felt better when you stretched me laying down.
Yeah.
So again, constant leading by the patient if they can communicate. Again, also looking at the nonverbal signs and symptoms of distress, and shifting your approach as indicated as well. And then I also will use biofeedback with fees, which I've kind of touched on before. So if I'm seeing a head and neck cancer patient during a dysphagia evaluation, and I know that they have a lot of internal lymphedema, or if I'm seeing a muscle tension dysphagia patient and I've done a fiber optic endoscopy, and their swallow anatomy looks pretty good, but maybe they're still, complaining of all this tension and strain, I will have the speech pathologist that's helping me with the study take over the holding of the scope, and I'll start to slowly apply some stretches and show them what it can do internally. And I've had incredible success after even just 45 minutes to an hour, couple days a week, doing these stretches, and then showing them under endoscopy what things look like again. So
That's
those
a
are
great,
some.
great, some great guidelines for clinicians. That's really great. I think a lot of times when somebody learns, well, not just this work, but any work, there's that that hesitation to do it because it's like, well, I got to be able to refine my touch so I'm good at it. And that's certainly a part of it. But over the last, I don't know, year and a half or so, since I came across Leah Halau's work on metatherapy, the understanding that we think it's the technique that's so the most impactful, and whether it's a manual therapy technique, although that's not how she applied her metatherapy concepts, it was in the broader aspects of voice that it's what surrounds our intervention. It's the words we use, it's the language we use, it's the context we place it. And that's what I try to do in the classes is not just show you here's what we do with our hands, but here's how we involve ourselves with the patient. It's what envelops the manual therapy that I think is more impactful than what we're actually doing with the touch. And to find Leia's work on metatherapy and see the alignment with the shared decision-making approach that we're using here, I think really, I don't know, I think it just adds credence to such a multifaceted approach, you know. There's another thing with manual therapy in the physical therapy realm is it really kind of gets limited positives because manual therapy, when it comes to pain, has been shown to be at best a short-term modulator of pain. That sometimes we can leverage that for greater gains through movement and exercise, right? But I think in your specific literature for the ENT SLP literature, you know, for muscle tension dysphonia, for muscle tension dysphagia, and a lot of the other conditions we're working with, you're seeing a more robust set of outcomes versus those limited short-term gains in pain when it comes to function. So when it comes to sort of skeptical clinicians, I think the evidence is, well, you know, any evidence can point in either directions, but you've got some decent evidence to underpin the use of this work.
Well, and to, add on to that, if I'm with a patient and, we've gone through the gamut of different things and manual therapy hasn't been attempted, oftentimes, even though the evidence isn't, strongly completed at this time, it's still evolving. I, again, will give the patient the option. And if they've demonstrated gains, it's still a win, even if there isn't evidence to support it yet. It's impacting that one patient, which I've seen, in almost every patient population that we have with this treatment approach. So I
And
think,
to me, it's always been that dilemma between outcome-based studies, which is sort of the underpinning of most of our work. But what really is lacking there is a decent mechanism of action examination, right? That, you know, everybody comes at it with their blinders on. No, it's about the tension. It's about the muscle tension. No, it's about the posture or the technique or whatever. It's like, well, understanding that when we do any intervention, the mechanism of action is nuanced and different for every patient and multifactorial. So I'm doing my little kernel of that, trying to get some evidence published when it comes to mechanism of action. But I just like to kind of implore new clinicians to say, you know what, we don't know exactly what it is that's happening when we touch somebody in this way, but can we ever really know for certain everything that's going on? And can you move on and actually use it without waiting for that full understanding to develop?
and I think too, just as a, profession, waiting until there's evidence, when we have all these patients that need us now, we're doing a disservice if we have this, at our clinical fingertips. And, again, I educate to the patients, this isn't the only thing we're going to do in therapy. It's going to be tailored to other things, traditional dysphagia exercises and MES. If you have EMST, IMST, like there's all the different interventions, but I will often use this as a, warm up to just kind of stretch everything depending on if that's indicated, to then impact the musculature, and then to document those objective measures like the test of masticating and swallowing solids if we're doing intraoral work pre and post, the E10, all of those clinical screeners that we can utilize immediately to discern improvement.
Yeah, that's great.
Yeah.
Sounds like you're really doing well with it. And I
I
love the videos that you and Brooke are putting out there on the fees combining with this work. So keep it up.
Yeah, it's been such an incredible tool. And I think too, just, you know, having learned it then and then where I am now, I probably use it every day with someone. And, you know, it's just such a confidence builder too for me as a clinician to know that I have that in my hat of knowledge and skills, and that, you know, we can be like other professionals that, you know, utilize this therapy, even though there's no coding for it yet. There will be, hopefully.
Unless you live in Texas.
Unless you live in Texas.
Yep.
Awesome.
Yep.
Everything's bigger in Texas.
Exactly.
Yep.
All right. Well, thanks so much for sharing your time with us.
Yeah. Thanks for having me, Walt. It's a great, incredible intervention for our patients and for speech pathologists. So thanks for seeing more than one area of need and providing your area of expertise.
My pleasure. Thanks again.
Thanks, Walt. Have a good one.